Hello student, today we will be talking about the excretory system or the renal system. What are the excretory product and how they are eliminated from the body. I am Dr. Hanjabam Barun Sharma. So, we will be taking this session on renal physiology and its relevance with the phlebotomy. What are the things which you are expected to know after this class? The first one, you should know the basic anatomy and physiology of the kidney and associated component of the excretory system or the renal system. What are the key excretory products which are to be removed from the body, and we have to identify how fill in the form of the phlebotomy or phlebotomist has to deal with what are the important blood investigation which are required in order to assess the renal function, and what are the technique which may be modified and which has to be the precaution which has to be taken in order to make the interpretation as well as the result and the investigation more accurate and least minimum discomfort to the patient. So, let us start the class. The first one, you have to understand what you mean by kidney and the basic physiology of the excretory. Kidney is there 24 hour into 7. It is a blood cleaner. We have a 2 kidney. It is a bean shaped organ about the size of your fist in the body, and it filters about 180 liters of blood daily basis, on daily basis, and the urine output is say 1 to 2 liters. So you can see how much work is done by the kidney. 180 liter of blood is filtered by the kidney, and out of that only 1 and 2 liter of urine is excreted daily. So reabsorption is also there. So which we will see the further in the slide. So it remove the waste, it balance the fluid and electrolyte, and it has a most important lots of important component which are essential for the life for the body. So this is very important because the kidney along with the ureter and the urinary bladder, they constitute what is known as the urinary system, and the functional unit of the kidney, it is known as nephron, and one kidney approximately contain 1 million nephron, and the function are of the kidney on an the most important one which we have focused is on the water and electrolyte balance, regulation of water and electrolyte balance, electrolyte composition, regulation of electrolyte composition. It may be related with the sodium chloride, potassium bicarbonate, etc., and the body fluid osmolality, regulation of body osmolality or osmolarity, extracellular fluid volume control regulation, blood pressure regulation is another very important component of the kidney function, and acid base homeostasis maintenance is these are the important point. So the kidney, they filter the blood, and urine formation is done, which is important for the excretion of the metabolic waste, like for example urea, ammonia, etc. These are the metabolic waste which has to excreted from the body, and certain chemicals like for example drug metabolites, foreign drug metabolite, it has to be excreted in the form of the kidney. And it also, the kidney also causes reabsorption of the glucose from the filtrate, which we will see later on. Amino acid is also reabsorbed, and there is causes it also help in the regulation of the calcium and the phosphate concentration regulation, like for example uptake from the plasma filtrate, which we will see in the subsequent slide what you mean by the filtrate. And the kidney also produce glucose, that is known as gluconeogenesis, like for example from different substrate like the amino acid and others, and 20% of the liver capacity, up to 20% of the liver capacity, gluconeogenesis is done by the kidney. Majority is done by the liver, but the kidney also plays an important role. And kidney is also an endocrine gland. Why? Because it secretes kinins, 25 dihydroxycholic acid calciferol, that is the activated from the vitamin D or the D3 calcitriol, and what you call it also lead to the production of erythropoietin, which is important for the production of the RBC, and also renin, which are important for the regulation of the extracellular blood volume, as well as the BP the regulation, which we will see in the subsequent slide. So this is the basic anatomy of the kidney. There are two kidney on the body on the either side, and these are the basic basic structure of the kidney. This is and this part is known as the renal hilum. This is the on the what you call the medial side of the kidney, which consists of the renal vein, renal nerve and a renal artery, and the parenchyma of the kidney, that is this is the capsule of the kidney which enclose the kidney, and this part, the medial part, the inner part is known as the medulla, the outer part is known as the cortex. The cortex is the outer part, and there are different renal columns are there, papilla are there, and this is also known as renal pyramid, because they are in the shape of the the pyramid, and this renal papillae, and they drain into what is known as the renal pelvis, and from the renal pelvis it drains into the urethra, and from the urethra it will go to the bladder, and from the bladder it will go to the urethra. So these are important point. Again, regarding the blood vessels also, which we can see that they are divided into different blood, like for example interlobar blood vessels, they are divided, and then interlobular blood vessels, and also the cortical blood vessels. So there are different the branches of the blood vessels, and these are the major and minor calyces are also there. If you see it, then this papillae, they drain into the what you call the minor calyces, and the minor calyces they form what you call the major calyces, and from the major calyces it will drain into the renal the pelvis, then from the renal pelvis it will go to the urethra. So this is the basic anatomy of the kidney. So here you can see that this is the anatomy, and if you see the kidney, the functional unit of the kidney, it is known as nephron. Nephron is the functional unit of the kidney, and this diagram is nephron. The nephron consists of what is known as the glomerulus, and this is the the capillary. This is known as glomeruli, and the glomeruli is enclosed by what is known as the Bowman's capsule, which we will see, and then this is connected to what is known as the PCT, or proximal convoluted tubules. These are the part of the nephron which I am talking about, and from the PCT then you have the what is called known as the DCT, or the distal convoluted tubules. These are known as the nephron loop, or the loop of the Henle, which we will study later on, and then it will further drain into what is known as the collecting duct, and from the collecting duct to the renal papillae, and from the renal papillae to the minor and major calyces to the pelvis and ureter. So the glomerulus along with the renal tubules, these are known as tubules, like for example PCT is tubules, DCT is distal convoluted is a tubules. So this they collectively, the glomerular plus renal tubules, they are part of the nephron, and the diameter of the glomerulus is approximately 200 micrometer, and it is basically a tuft of capillary, which is known as glomerular capillary, and this capillary has a relatively higher hydrostatic pressure, approximately 60 millimeter mercury. Why this is important? Because the kidney function is filtration, and for filtration the higher hydrostatic pressure is required. So these are encased in what is known as the Bowman's capsule. Bowman's capsule surround this the capillaries, and the filtration, the filtrate, the plasma filtrate, which we call as glomerular filtrate, it will form from the blood, from the plasma which is present in the glomerular capillary into the Bowman space, and this together, this is known as renal corpuscle. So renal corpuscle is basically the Bowman's capsule with the glomeruli. The filtrate is from the glomeruli, and this is the filtrate is the beginning of the formation of the urine. So urine is first formed in the form of what is known as the glomerulus, from the glomerulus into glomerular filtrate, and absorption, excretion, tubular absorption and tubular secretion, and further processing, it will lead to the formation of the urine, final urine product. Easily you can see that the distal tubules, they the distal tubules, they connect it to what is known as the connecting tubules. They fall into what is known as collecting tubules, and the cortical collecting tubules due to the cortical collecting tubules. For this collecting connecting tubules to the collecting tubules, this is connecting. Okay, this spelling is connecting to the cortical collecting duct from in the cortex, then it will drain into what is known as the medullary collecting duct, and from the medullary collecting duct through the renal papillae it will fall into renal pelvis, and from the renal pelvis urethra, ureter, bladder and urethra. Basically this is a diagram which how the kidney, the formed kidney from the glomeruli is drained into the renal pelvis into the urethra and expel out from the urethra. So this is the basic the anatomy. Again, the blood supply. Let's talk about the blood supply. This is the renal artery in the hilum. You can see that. Then from the hilum, then we can see that the segmental artery is there. Then interlobar artery, between the lobe of interlobar artery is there. Then it rise to what is known as the arcuate artery, and from the arcuate artery interlobular artery is there. So these are the different things, and you can see that from the interlobular artery it gives an afferent arterioles, and this afferent arterioles is the one which supply the glomerulus, that is the glomerular capillary, and from the glomerular capillary then efferent arterioles is there. So remember, there is two arterioles between the capillary, that is the afferent arterioles, glomeruli, and then the efferent arterioles, and after this efferent arterioles it will form what is known as the peritubular capillary. So there are basically two capillary network. The first one is the capillary in the renal corpuscle, which is the glomeruli, and another is the peritubular capillary which surround the tubes of the tubules of the nephron. See, this is the tubules of the nephron, like for example lobe of the Henle, descending and ascending lobe of the Henle is surrounded by the capillary peritubular artery capillaries, and from the capillaries you can see that the vein it drains into what is known as interlobular vein, from interlobular vein to the arcuate vein, and from the arcuate vein to the interlobar vein, and from the interlobar vein into the renal vein, and from the renal vein it will go to the the vena cava. So the two kidney basically they receive approximately about 22 to 25% of your cardiac output, that is 1.1 to 1.2 or 1.3 liter per minute. So much blood is supplied per minute to the kidney, and at a given time 30 to 40 ml of blood is present in the renal capillaries. Okay, and the two capillaries bed are present, like I have already told. One is known as the glomerular capillary, this one, and another is a peritubular capillary, this one. So there are two capillary system is present, and in the glomerulus capillary it has a relatively higher hydrostatic pressure, like approximately it may be 60 millimeter mercury or 45 to 60 millimeter mercury, or approximately equal to the say 40% of the systemic the arterial pressure, which is higher as compared to other capillary system. Why this is important? Because it will favor the ultrafiltration process, that is formation of the glomerular filtrate, which will be formed in this space which is known as the Bowman's capsule, the Bowman space. So peritubular capillary, the capillary here is the peritubular capillary. It has a lower hydrostatic pressure, approximately 8 to 13 millimeter mercury. Why this is important? Because it favor absorption, reabsorption of the blood. Remember, 180 liter of the fluid is blood is filtered by the kidney per day, but only 1 to 2 liter of urine is produced. That means maximum more than 99% absorption is there. So absorption is also very important, filtration is also important, and absorption is important, and this absorption is favored by the low hydrostatic pressure in the peritubular capillary. So this one has to understand. The total surface area of the renal capillary is approximately equal to that of the tubules, and which is about 12 meter square, and the diameter of the efferent artery, this efferent artery, if you see the diameter of the efferent efferent and afferent, and you can see that the diameter of the afferent artery or afferent that is going to the glomerular tubular is slightly larger as compared to the efferent artery. So this arrangement helps to form a slightly higher hydrostatic pressure in the glomeruli, and by changing this resistance of the afferent and efferent arterioles, by regulating that, then you can regulate the hydrostatic pressure, then you can regulate the glomerular filtration, and also the tubular reabsorption by affecting the hydrostatic pressure etc. in the peritubular capillaries. So this concept is important. So, again this is the one, this is the cortex of the kidney, this is the medulla of the kidney, and you can see that these are the different glomeruli are there, and these are the different part of the nephron, that is a proximal convoluted tubule is there. Then we have the loop of Henle, descending loop of Henle, ascending loop of the Henle. Then you have the DCT, that is distal convoluted tubules. Then you have the connecting duct and collecting duct, and finally everything falls into the renal papillae. The form urine is fall into renal papillae, and from the renal papillae to the ureter. So, another important point which one has to understand, if you dissect this one cross sectional area, if you see in a microscope, then you can see the structure something like that. So, this is basically the arteriole, this is the afferent arterioles, this is the efferent arterioles, and these are the glomeruli, the capillaries of the glomeruli, and you can see that these capillary glomeruli are surrounded by epithelium, which is known as podocyte. We will see we will discuss the further this thing, and here this is the space in the Bowman's capsule, and this whole structure is known as renal corpuscle. So, the blood is going to the to the afferent arteriole into the glomeruli capillary, and then filtration happens. Then the filtrate is collected here, and from the collected filtrate, and it goes to the proximal tubules, and from the proximal tubules to the loop of Henle and the others. So, there are certain cells which one has to understand. So, the first part is the proximal tubule, and this proximal tubule will lie to the loop of descending and ascending loop of Henle, and this ascending loop of Henle will again come near the glomeruli, and this is the part of the DCT, that is the distal convoluted tubules, and you can see that near the afferent and efferent arterioles, the part of the DCT it lies near the efferent and afferent arterioles, and you can see that this is a specialized cell is present in that part of the distal tubules there, and these cells are known as macula densa. The macula densa is important because they sense the amount of the concentration of the sodium and chloride in case of the fluid in case of the fluid which is present in the tubules, and these are the cell, these are the juxtaglomerular cell. These are certain cells are there, these are juxtaglomerular cells, and these cells are important because these cells they secrete a hormone which is known as renin, which is important for the regulation of blood pressure and blood volume, and this renal nerve which are directly supplying in the different arterioles. Similarly, in the microscope you can see that this is a macula densa, this is the PCT, this is the different brush border of the proximal convoluted tubules, and this is the glomeruli. This structure is the glomeruli, and this is the basement membrane. So, basically juxtaglomerular apparatus, it consists of macula densa number 1. This macula densa, they are present in the initial part of the distal tubules, and they sense they sense what is known as sodium and chloride concentration in a tubular fluid. Then we have the JG cells, that is juxtaglomerular cells in the wall of the afferent and efferent arterioles. Like for example, here you can see that in the wall of the afferent arterioles they secrete the renin, and also the mesangial cell, with these are known as extraglomerular mesangial cell. They are known as Lacey cells. These are the cells which are surrounding the arterioles, but they are extraglomerular, outside the glomeruli. So, this they form what is known as juxtaglomerular apparatus or JG apparatus. These are very important for the regulation of the blood volume and the blood pressure also. Again a similar thing, these are the more detailed diagram. This is the renal corpuscle, afferent arterioles, efferent arterioles. There are different things. This is the part of the PCT, this is a part of the DCT. These are the different this thing. Why the study is important? Because the filtration happens from the blood plasma which is present here, and it has to pass all the way into the what is known as the space in the Bowman's space, that is Bowman's space, or which is also known as the urinary space. So, it has to pass from the endothelium, then the basement membrane, then the epithelium of the the glomeruli, that is renal the corpuscle. So, this basically form what is known as the filtration membrane. The filtration membrane is first formed by the capillary endothelium, and this endothelium, these are capillary endothelium, and this endothelium they contain small holes or the fenestration, and this will favor the filtration process. Then the basement membrane is there. Number 2 is the basement membrane, and number 3 is the epithelial cell. So, number 2 is the basement membrane, and number 3 epithelial. This is the epithelial cell which I am talking about, and this epithelial cell are not continuous. Like for example, one epithelial cell is here, one is another. They are not continuous. They have a long foot like processes or pedicles, which is known like here. So, that is why they are known as podocyte, foot like podocyte. These are this cell are known as podocyte. They are not continuous. They have a long processes like pedicles, and they are separated by a slit pores. So, they are separated by a slit pores. So, all this thing is important because they favor the filtration the process. Again, seeing this filtration membrane from a different perspective, this is the the capillary endothelium. This is the endothelium, blood is there, and this is the surrounded by the endothelium. You can see that different, it is fenestration are present, there is small holes are present, and then the basement membrane is there, and then there is the these are the podocyte. Epithelium layer is there, and this podocyte has a foot like processes with a slit the in between. So, this is basically the filtration glomerulocapillary and the filtration the membrane. Again similar thing. Here you can see that this is a nephron, glomeruli is there. If you expand it, then you can see that these are podocyte, and their processes are there, like for example primary processes are there, foot processes are there, and the basement membrane is always present. Then this is the endothelium is present inside, like for example this is the plasma is there in the blood, this is the endothelium, and this is the glycocalyx is present, and then endothelium cell is there present, there the fenestration is present. These are the foot processes of the podocyte, and this is the slit diaphragm, they are not continuous. So, the filtration happens from this direction to this direction into the Bowman space from the capillary side. So, this is basically the the process of the filtration. Again same thing, glomeruli, Bowman space is present, the whole thing is known as renal corpuscle, and when the filtration happens, the fluid is collected here, and it will go to the proximal tubule. From the proximal tubule, further processing is happening in the distal loop of Henle, and from the loop of Henle to the DCT and to the collecting ducts and all this thing. So, this process of filtration is known as the glomerular filtrate, and the rate at which it is filtered, it is known as GFR or glomerular filtration rate. This is very important because glomerular filtration rate tells you about the function of the kidney. So, GFR is basically the amount of the plasma ultrafiltrate which is formed each minute per minute. How much is formed? It is approximately equal to 125 ml per minute or 180 liter per day. That is why we said that the kidney, the two kidney filtered about 180 liter per day of blood, plasma is there, and this is approximately equal to the 60 times the plasma volume or 4 times the total body water present in your body, and the urine output is only 1 liter or 1 to 2 liter. That means more than 99% of the filter is reabsorbed by the system, and this reabsorption is basically done by the tubules, different part of the tubules, like for example PCT, for example the distal DCT or the collecting duct and the other thing. So, the measuring GFR is very important because it will help you to assess the renal functioning of the renal, and this measuring can be done by measuring the plasma level of a substance and the amount of the substance which is excreted, that is in the urine. How much it is excreted in the urine, how much it is present in the plasma, by measuring that thing you can measure the GFR. Like for example a substance like inulin is an example, a substance which is freely filtered through the glomeruli into the Bowman space, and they are not absorbed or excreted by the tubules. That means whatever it is present in the plasma, it is present filtered, freely filtered in the presence in the glomerular, filtrate in the Bowman space, and then it is excreted as such in the urine. So whatever it is present in the urine, it will tell you the concentration or the amount which is present in the glomerular filtrate. There is in between, there is no absorption or excretion. So this is an ideal substance, and inulin is one of the substance. By measuring its concentration in the blood, in the urine, we can predict the GFR, glomerular filtration rate, enhance the functioning of the kidney. The kidney, like I have already told you, it is about 180 liter per day GFR. It is approximately equal to the 20% of the renal blood flow. 20% of the renal blood flow happens, and this process of the filtration, it follows the rule like we have already studied in the other system, like in case of the respiratory system, in case of diffusion across the respiratory membrane. Similarly, here also you can see that the GFR is determined by what is known as glomerular ultrafiltration coefficient, which is nothing but the product of the glomerular capillary wall hydrostatic conductivity, that is permeability, how much the membrane, the filtration membrane is permeable, and multiplied by the effective filtration surface area. So the more the surface area, the more filtration will be done. So the product is nothing but the what is known as the KF, which is the glomerular ultrafiltration coefficient. Then this is the hydrostatic pressure in the the capillary, that is glomerular capillary. So the more the hydrostatic pressure, the more will be the filtration, and this is opposed by the hydrostatic pressure which is present in the tubules, that is the Bowman space. If the more hydrostatic pressure is present in the Bowman space, then it opposes the filtration. So this hydrostatic pressure favors the filtration. The hydrostatic pressure which is present in the glomeruli favors the filtration, whereas the hydrostatic pressure which is present in the Bowman space, it opposes the filtration. Similarly, there are known as the oncotic pressure. Oncotic pressure is basically the pressure, the suction pressure, the inward pressure build up because of say plasma protein. So oncotic pressure in the in the glomerular capillary, it opposes the filtration, whereas the oncotic pressure which is present in the tubules, that is Bowman space, it favors the filtration. But since the way proteins, they are not filtered as such normally, therefore the oncotic pressure at the Bowman space can be considered to be 0. So basically the three things are important. The first one is the hydrostatic pressure in the glomerular capillary, hydrostatic pressure in the tubules, that is the Bowman space, and oncotic pressure of the plasma in the glomerular the capillary. So these are the important determining factor, considering the glomerular ultrafiltration coefficient remains the constant. So this one has to understand. Similarly, if you fill in the value, like for example blood hydrostatic pressure is approximately 55 millimeter of the mercury, the blood oncotic pressure is approximately 30 millimeter mercury, and the capsular hydrostatic pressure that is present in the Bowman space is 15 millimeter mercury. So if you fill this value in the formula, then you can see that at 10 millimeter of mercury of net filtration pressure is present. So net filtration pressure is present, it favors the filtration normally. Another concept which one has to understand is what is known as the clearance of a substance. What do you mean by clearance of a substance? It is a volume of the plasma that will be necessary to supply the amount of the substance excreted in the urine per unit time. That is, per unit time, how much it is excreted in the urine, per unit time, that substance, that's the amount, it is the volume of the plasma that is required to be supplied to the kidney in order for that amount of substance to be excreted in the urine per unit time. So this is basically it follows the law of conservation of the mass. Like for example, this is the concentration of the substance, this is the concentration of the plasma volume. So PS is it is the concentration of a substance, and CS is nothing but the clearance, that is the volume of the plasma. So if you multiply the volume into concentration, it will tell you the amount which is present in the plasma. And similar, this is the US is the urinary concentration of the substance, V is the urine volume. So urine volume into concentration equal amount. So the amount which is presented to the glomeruli has to be equal to the amount which is excreted from the body. assuming that there is no reabsorption or excretion in between. So this is the clearance of a substance. So clearance of a substance is basically, it can tell you about the GFR, glomerular filtration, if that amount is not excreted or secreted by the renal tubules. So inulin, the clearance of inulin is approximately, it comes to around say 126 or 125 ml per minute, which is the GFR. That is, if you multiply 35 milligram per ml of the concentration of the inulin in the urine into the 0.9 ml per minute, that is the urinary flow, the volume, that is urine flow, divided by the plasma concentration of the substance, which is approximately 0.25 milligram per ml. So it will approximately give rise to 126 ml per minute, which is the GFR. Or you can or if you fill this another value, that is 125 milligram per ml of the urinary concentration of the substance into the 1 ml per minute of the urinary flow, divided by 1 milligram per ml of the concentration in plasma, it will give rise to 125 ml per minute with the GFR. So GFR can be measured by measuring the clearance of the inulin, but for that you have to inject inulin to the body, inside the body. So we have to seek alternative method. One alternative method is known as creatinine clearance. So creatinine is a endogenously produced substance in the body as a part of the metabolic end product of what is known as muscle creatine. So and this, by using this volume, by using this clearance, we can approximately estimate the GFR. But one thing which you have to understand is some amount of the creatinine is secreted by the tubules, renal tubules. So that means the GFR estimated by this creatine clearance may be slightly higher than the actual GFR, or the GFR which is estimated by the clearance of the inulin. So this one has to understand. The advantage is that creatinine is endogenous. You don't have to inject anything in the body. Another one is in some renal patient, it may be very difficult to assess the collect the urine also, or urine concentration also. So we can simply take the PCR, that is plasma concentration of creatinine, and this plasma concentration can be taken as a indirect marker of the renal function, because it is inversely proportional to the GFR. So which is approximately normally equal to 1 milligram per deciliter. If it is increased beyond that, then we can see that the every other system is normal, then we can see that there is the renal function may be impaired, because clearance of the creatine is reduced, the plasma concentration will increase. So this is the way in which we can understand this concept. The other substances are also there which are used, like for example thelamide is there, chromium the ethylidene diamine tetra acetic acid or EDTA, cystatin C. These are the other things which can be used to estimate the GFR, but clinically cystatin C and the creatinine is most commonly used. Creatinine clearance is most commonly used. So this is basically the process of formation of urine. From the afferent arterioles, it will fall into glomeruli where the filtration happens, and this filtration into the Bowman space, and this is basically the process of the filtration. Then some amount is absorbed by the peritubular capillary, which is the process of the tubular reabsorption. Then some amount is excreted by the by the tubule from the pericapillary peritubular capillary, which is the process of secretion. Then finally the foam urine is excreted by the process of what is known as micturition or urination. So this is the concept. The excretion is basically equal to the filtration minus reabsorption plus secretion. So in this way the final urine formation happens. So the first filtration resembles the plasma, because it's just unprocessed urine. It's very much resemble the plasma. Then it passes down the tubules. The volume reduction happens. Reduction of volume happens 180 from 180 liter per per day to 1 to 2 liter per day. Then volume tubular reabsorption and excretion happens, and finally it is out by the process of urination or micturition. Same thing in this diagram you can see that the the afferent arterioles is there, then Bowman space the filtration happens, then proximal tubules reabsorption excretion is there, and ultimately formation of the urine. So, glomerular filtration initially the osmolality, if you see the osmolality or the osmolarity, it is similar to the plasma, which is 300 milliosmol per liter if you say the osmolarity, or 300 milliosmol per kg if you see the osmolality. So, basically osmolality is also same in the glomerular filtrate, but as the processing happens in the tubules, ultimately by depending upon the requirement of the body, the osmolality can increase or decrease. So, these are the different part of the nephron and how processing happens. So, we will just see in this diagram different different segment has a different important role. Like for example, glomerular filtration happens here, and then the PCT, reabsorption of the say different ions, water, nutrients, removal of the toxin, adjustment of the filtration of the pH, pH, maintenance of the pH is also an important part of the kidney, the important function of the kidney. Then there is the ascending ascending and the descending lobe of the Henle. This is the descending lobe of the Henle. From descending, it is the ascending lobe of the Henle. So, in the descending lobe of the Henle, there are different aquaporins are present, and so water passes freely. That's why it is known as concentrating segment. Then in the ascending lobe of the Henle, it is relatively in the especially the thicker part, where water permeability is not there. So, it is also known as diluting the segment. It reabsorbs the sodium and the chloride from the interstitial fluid, and you can see that then we have the DCT, that is distal tubules is there. It selectively excrete or reabsorb different ions, electrolyte, and also maintenance of pH is also there. Then it will go to the collecting duct, where further reabsorption of solid and water happens, like for example in presence of different hormones like aldosterone, aldosterone directed hormone, water absorption is there. So, different things are there, and ultimately the final product is formation of the urine. Similarly, same thing happens, like for example, these are the different things which are reabsorbed or excreted reabsorbed in the PCT, like for example glucose reabsorption is the amino acid reabsorption is a vitamin, lactate, urea, uric acid. These are the different electrolyte. So, electrolyte balance, maintenance of electrolyte concentration balance is also an important part of the kidney, and this is a similar thing happens in the PCT. These are this part, like for example hydrogen ion, ammonium ion, uric acid, urea, creatinine, some drugs is there. Water reabsorptions happen here, and in case of the descending lobe of Henle, then urea reabsorption also happen in the thin part of the ascending limb, and the thick part of the ascending limb of the lobe of the Henle, you can see the sodium potassium chloride reabsorption is there without water. So, it is also known as diluting part. Then DCT, you can see the reabsorption of the sodium chloride, bicarbonate, water is there. Then ammonium, potassium, hydrogen ion reabsorption is there, water and urea reabsorption is there. So, different part has a different role, and that is why as a function there is an overall kidney has an important role in case of the electrolyte and water balance system. Similarly, in this detailed diagram also you can see that the same thing in different diagrammatic form it is presented here, because this is important. So, I am focusing here again a glomerular is there, then secretion PCT, different secretion reabsorption is happen, lobe of Henle, ascending limb, descending limb, then DCT, then collecting tubules. So different part of there, like for example it is impermeable to water, this part is not permeable to water, especially the thicker part here and this is the permeable to water. So, it is known as the concentrating segment, this is the diluting segment, and these are the permeable to water, and also depending upon the different hormones. So, why this is important, because if you see the permeability or depending upon the permeability absorption of the solid with respect to water, or absorption of the water with respect to solid. So, different things are there, that is why osmolality may increase or decrease. Like for example, when the lobe of Henle, descending lobe of the Henle, when it is entered, the osmolality is approximately around 300 milliosmol, and you can see the different part at lobe of Henle. This is the ascending part, this is the descending part, and you can see that dilution happens in case of the ascending part, concentration happens in case of the descending part, and it can reach to around 1200 milliosmol per kg osmolality in the tip of the loop of the Henle also you can see that. So, how different concentration gradient is maintained because of this. These are important for the different reabsorption. There are different reabsorption of the processes, and this process is also known as counter current the multiplier, and then different peritubular capillary, they also help in order to maintain this thing which is known as counter current the exchanger. So, these are the different thing why the maintenance of this the osmolality gradient is present in the nephron, different part of nephron, and subsequently excretion or reabsorption of water is also important. Similarly, different drugs can be given which act on the different segment of the nephron in order to produce different diuresis or increase secretion of the urine or water part of the urine. So, I will not go into the detail. Different thiazide different potassium sparing diuretic osmotically the active diuretic, loop diuretic. So, there are different drugs are also, they can act in a different part of the nephron in order to exert their the action. Similarly, same thing here, I will not go into the detail. So, these are the different part of the renal nephron where associated with the different the function. So, let us come to the waste product. So, the waste product may consist of the different thing, like for example, creatinine is a waste product, urea is a waste product from the amino acid metabolism, creatine from the muscle creatine metabolism, uric acid from the nucleic acid metabolism, bilirubin from the hemoglobin breakdown, and the metabolite of the different hormone. So, if renal failure is there, then creatinine rise may happen, urea rise may happen, uric acid may increase. So by measuring all these things, you can approximately know you can guess the function of the kidney. Like for example, urea if all this increases, then the kidney is not working properly, and you can say that the kidney function test is impaired. So, all this thing can be measured from the blood. So, that is why that is the importance of the investigation by drawing blood from the body, that is phlebotomy is important in order to assess the renal function by measuring urea, by measuring creatinine, by measuring uric acid. So, electrolyte imbalance is a delicate dance, because all many other systems for important function of the body, like for example, for heart, like if the potassium goes very high, then the heart may stop also, the person may die also. That is why the kidney plays an important role in the critical role for maintaining the concentration of the different electrolyte. The sodium, potassium and chloride we have to measure by using blood, proper blood investigation, and this may help assess the different, like for example, sodium, by assessing the sodium function we can tell about the fluid balance, we can it is important for the nerve function and lots of other things, and the potassium is important for the heart rhythm, proper heart rhythm, for proper muscle function, and chloride is also acid balance. Also we can do the arterial blood analysis of the blood gas analysis, and you can see acid base balance also, and these are the different tests which are required to have a renal function, which is also known as a renal panel. Like for example, BUN, blood urea nitrogen, its level increases, that means the early kidney stress is there if the urea level increases, and creatinine is important, muscle protein muscle creatinine waste product, gold standard for the kidney function, because like I have already told you, the clearance of creatinine may predict the GFR, and GFR is an important function of the kidney. So, by just measuring the plasma creatinine, you can predict the many things. So, estimation of the creatinine from the serum is also important, and eGFR, E is nothing but the calculated GFR can also be calculated by measuring the serum creatinine from age, sex, race, different type of the ethnicity, male or female. So, by using a different formula, you can calculate the eGFR, and different grading of the kidney disease can be done. This is important. So, electrolyte estimation of the different electrolyte like sodium potassium chloride extra, they are also form an important part of the renal function. Uric acid, blood gas analysis, bicarbonate, calcium phosphate estimation, these are all important part of the kidney renal the function test. So, GFR, like I have already told you, it can be calculated clinically. There are different formulas are there. So, different which one is useful, which one is not useful, all these things. So, most commonly used the method they use the serum creatinine level, age, sex, gender and everything. So, measurement of the serum creatinine is important, and these are the different grading of GFR. If the GFR is less than 60, you can see that there some loss of function is happening, that is possibility of the chronic renal disease. If it is less than 15, then it is known as the end stage renal disease, dialysis is required. So, a proper grading, diagnosis and prognosis of the renal disease can be done by measuring the eGFR. And one mistake from your side or one mistake in case of the blood investigation, then the error may happen, like for example violently sacking. If sacking is done, then hemolysis can happen, potassium can go out from the red blood cell, it will increase the potassium, and if you erroneously estimated potassium to be very high, then it is because high potassium is maybe associated with the cardiac the arrest. That is why false the alarm may be raised. So, suppose in this case, if the potassium reported to be 68 and again if redraw, the blood was redrawn again and it shows 4.2, that means it was the tube was second. Like anything, because of the sacking of the tube, the potassium level may increase. So, vigorous sacking should be avoided. Instead, you can gently invert the tube 5 to 8 times if required. Then small, instead of using a small needle and fast pull technique which may destroy damage the red blood cell, hemolysis can happen. So, more 21 gauge needle or larger needle can be used. Alcohol should be, when you when you use alcohol as a universal precaution, you should wait it to be dry. Then only after your syringe, your needle has to be injected. Otherwise, the hemolysis can happen. That's why 30 to 60 second wait is there till the alcohol dries. Tourniquet, if you use tourniquet, it should be released within 1 minute, because if it is if the tourniquet is left in this place for more than 1 minute, then it may alter the biochemistry of the blood. It may affect the result also. So, this one has to understand. So, there are certain things which as a phlebotomist one has to understand, certain precaution, like for example, and also another important point is which type of the tube one has to use. Like for example, in case of the BUN, in case of the creatinine and also electrolyte, then we may use what is known as a gold top or SST. SST is the serum separator tube, or the plain red tube can be used. They contain what is known as the blood. This SST, they contain the gel separator or blood the coagulation separator, or if it is not present, then it is the red blood. These are important because you want to get the serum, and you can do inversion up to say 5 times, and eGFR can be calculated by using from the serum creatinine level. You can use the plain red vial or the gold SST vial, and if you use what is known as lavender color vial, it contains EDTA, and EDTA they binds with the calcium, and the calcium level may decrease, the false result may happen. That is why a proper tube vial noting is use of the proper vial is very important. So, it's and how much volume has to be filled, like for example, for a SSD vial up to 2/3 of the volume is filled, or under it is generally if you do much under filling, then it will incorrectly serum ratio may be incorrect. That is why how much it has to be filled is it's also important. Vigorous sacking should not be done because the RBC rupture can happen. Potassium may be very high. Instead, invert 5 to 8 times. Inversion can be done. Do not sack. Use of the small needles, it may rupture the RBC. Instead, use 12 gauge or more. Very ensure a very steady, smooth flow of the blood. Then you should not draw the blood where a fistula is there for dialysis, or a IV site is there. You should not use that site because dilution can happen, hemolysis can happen from the I will feel, that's why your the value will change. So different from the venipuncture side, from the away from the IV set, one has to use. So and alcohol has to be let to dry, otherwise hemolysis can happen. Wait until 30 to 60 seconds, let the alcohol dry. Tourniquet should be left less than 1 minute, not more than 1 minute, because it will causes stasis of the blood, it may damage the cell. So this one has to understand. So a phlebotomy is if the sacking of the vigorous sacking of the tube is done, then whole chemistry will be disturbed, investigation is not reliable. So this one has to understand. A proper correct tubing, use of the proper correct tubing is very important. Like for example, gold SST or the red vial can be used. Lavender is generally avoided because falsely calcium may comes to be low, potassium may be falsely high. Green contain the heparin, they may alter the sodium potassium result also. Sometimes they may be used in case of the electrolyte, but is always better to use the gold SST or plain red. So this one has to understand. So a renal panel, we generally use the SST or the red vial. The order of the blood drawing is also important. First, for the blood cultured, like by using a different blood cultured bottle, yellow or special media bottles are generally used. Then you can draw the blood by using the gold SST or the red vial, which are important for the renal tables. Then you can use the green, lavender and the gray. Why? Because if you draw SST in the blood after the lavender, then EDTA carryover may happen, which may fully decrease the calcium. So generally we follow this protocol, and this was this standard order was given by what is known as Clinical and Laboratory Standard Institute, that is CLSI. So this one has to understand, and contamination has to avoid it, because if it is not done properly, then result may vary, and if the result vary, then treatment will be the prognosis will be affected. False information will go. So this one has to understand, and the volume is also important. Like I have already focused for gold SSD up to 2/3, at least up to 2/3 you have to fill, and for the red vial, the full draw filling up to the mark. This is very important. Inadequate blood may lead to inadequate or inappropriate result. So gold or plain red is generally used for a renal this thing. Tourniquet has to be less than 1 minute, 21 or more gas. Dry site, the alcohol has to be dried. The culture, for the blood culture, it has to be drawn first. Then for a renal, after that the EDTA tubes can be used. It has to be clear, you can fill the volume up to 2/3, at least up to 2/3 or full. No pinkish thing should be, that is hemolysis, breakdown of the RBC, hemolysis, it will give rise to the pinkish thing color. So there should not be any hemolysis, and complete clotting, because if clotting is happens, then only serum will be there, because serum is used for investigation. So you have to allow sufficient time for the complete clotting to occur, and the appropriate handling is very important, because appropriate eGFR estimation require good exact estimation of the creatinine, serum creatinine, and all other parameters, and renal function, interpretation of renal function depends upon that. So it depends upon how you are handling the sample, how you are doing the technique. So take away point is very important for the kidney. BUN, creatinine, uric acid and other things are there. eGFR is a report card which require the creatinine and certain formulas. Potassium level you have to see. If you violently check, it will go like anything. Hemolysis, you have to avoid the hemolysis. Okay. Proper draw technique is very important. Proper filling up to the proper mark is very important. Patient safety is very important, because the patient are weak, the patient are anemic, the patient are edematous. So you have to be very careful. If in case of the doubt, it's always better to redraw, never guess. No guesswork. So you have to do like that, and the serum separation has to be done, say, within 1 hour or so after proper clotting is allowed. So you are the first line of defense. That means a perfect draw of blood is very important. It can prevent the dialysis tomorrow. That means proper treatment if given the kidney for the kidney patient. Avoid dialysis site for drawing of the blood. I have already focused with the no drawing from the arm which has AV fistula or IV line or the graft which is for used for the dialysis. Avoid blood collection immediately after dialysis if not indicated, because it will change the chemistry. Patient safety is very important. Proper handling is important because the patients are prone for anemia, dizziness, infection. The edema, they are very weak. There is a fluid imbalance because of the renal problem. The veins are fragile. Vascular damage can happen, and no excessive therapeutic time. One has to understand. So, by understanding all these things, just think over this question: how will you change your technique after learning about hemolysis and potassium? If you find hemolysis and potassium, how you are going to change your technique? Think about that. Recall the today's lecture, and I hope it will help you. Thank you very much.